So just a few words about our company for those of you that are joining us for the first time. SourceMed is the leading provider of solutions for the outpatient healthcare industry. Many of you are familiar with our Therapy Source software. We also have several services, including billing and consulting. In addition to the therapy market, we serve ambulatory surgery centers and other outpatient facilities across the country, and we have for over 30 years. And so many of you also know our host. David McMullen is the Chief Therapy Officer here at SourceMed. David's a physical therapist with over 20 years of experience in a variety of healthcare settings, and he shared his expertise with many industry publications and organizations. He was also one of the chief architects behind the Therapy Source software, and he continues to be our expert on all things PT here at SourceMed. So with that, I will turn it over to you, David, to catch all of you up on the latest with the proposed rules and final decisions, including some information that's extremely recent from yesterday's APTA business meetings. So David, over to you.
Thank you, Megan. I appreciate that. And I think Megan might have said this at the beginning, but I know that there is a lot of material to cover, and so also keep in mind, as I know some of you are treating patients or on a break, or you may have to come in and out, and we understand that. We are recording it, so the recording, the link to the recording and the slides will all be available to you at the end. Megan will make sure you get them. And if you've got some partners, some teammates, et cetera, who couldn't do this or couldn't attend, whatnot, also anybody who registered who couldn't attend, we'll also make sure and we'll send them a copy of the recording. So I wanted to make sure you were aware of that, because there is a fair amount of stuff to cover, which it seems to, in the regulatory environment these days, there's no shortage of content from quarter to quarter. So let's talk about what we'll cover today. So a bunch of stuff coming for the end of the year as we head into the third and fourth quarters. So we're going to talk about the ICD10 changes that have been finalized that are coming October 1st. I want to update a little bit on the bundled payment expansion. Won't spend a ton of time on that, but as we went into a little bit of detail on some of the more previous sessions on both some of the macro initiatives, alternative payment models, et cetera, and we know that the CJR model is actively underway. You know, this is a train that's coming and can't be avoided. So just awareness and being prepared. If you may already be participating, I want to make sure we just drive and continue awareness, because the payment models are changing, and so we need to make sure you stay in the loop. Obviously, the physician fee schedule. So the Medicare physician fee schedule, the proposed schedule or rule, was published in July. And so we'll talk a lot about some of the core aspects of that. Obviously, it's a big document, but we're really focused on the stuff that pertains to outpatient therapy and what that means to us as we prepare for the final rule in November, and obviously Jan 1 next year. A little bit of an update on macro, or the MIPS component of macro, which was scheduled to go live January 1st from the physicians starting off with that. So again, a little bit of a brief update on that. The bulk of the time is going to be spent on ICD-10, physician fee schedule, and some other regulatory things I want to make sure everyone's aware of. So I'll cover those general regulatory updates. There's kind of a broad spectrum of active legislation, and then the resources. What you see in the resources, it's pretty complete. It's all the things I pull from, all the things I've attended, things I've engaged with that becomes the source of the content. And but the final slides, I actually got some more resources that I may want to include. So I'll probably update the slides just by adding some more resources for you, just so you're aware of it, because they're always get you to the right place to review the information in more detail. But it's a lot to be able to cover in an hour. So I appreciate your time. So let's talk about ICD10CM changes. And again, we're just going to cover the CM changes. I'm not going to worry about the diagnosis code, PCS codes that don't really affect us. So let's just talk about them. So when we get into the 2017 ICD10CM changes, so they were released in June, and they've been finalized now. And these codes will go into effect October 1st, but they're not effective before that. There's approximately 2,300 or so new codes, ICD10CM codes. There's a little over 500 revised codes, and there's 200 some odd deleted codes. And that's in its entirety, not just the code specific to our scope of practice, but I'll show you a little bit more detail about that in a second. So I created a link, and a lot of times throughout the presentation, you notice I've created links where you can go directly to sources to get all the information, as well as I always put in the resource section for you as well. So the diagnosis codes can be found on that link, which also gives you some updated GEMS access as well, which should really help you. So the other things that were updated and released kind of since June, so they updated some additional guidelines. And again, the link is there at the bottom of this slide and in the resource section. But there were some pretty big changes in the guidelines themselves, as it pertains to excludes and some of the other changes. So when you look at the guidelines, it's always good. The updates specifically, because it's a huge document, the guidelines. So just focus on any narrative changes are always in bold. Underlined changes have been moved within the guidelines, and italics are headings that have been revised. So you can use sort of the bold, underlined, italics to kind of focus in on the changes specifically to the codes and the code areas or chapters that you guys use and that may impact you in your practice. So it's a pretty big update, right, because they froze the codes. So it's the first update to the code set since actually 2013 because of the code freeze. So keep in mind as we move forward into next year, we probably won't see as many changes in the codes, but there's a larger volume of code changes because of the code freeze moving from 9 to 10, and they had to freeze the codes. Big focus, obviously, is a lot more continuing to drive more and more increased specificity around diagnosis codes, which really helps patient populations and really helps with data gathering and overall initiatives like population health, and be able to help us drive treatment patterns and treatment efficacy as we provide, can demonstrate value on specific patient populations. So let's talk about not a ton of time here, but I broke this down, or we broke this down by chapter, so you can kind of see by the chapters as you look at all the various chapters, from chapter 1 to chapter 21. So where were the adds, where were the revisions and deletions? So some chapters more than others, and not a lot of these first 10 chapters do we spend a fair amount of time in, or do we use? We do use some, but certainly not many. So as you can see just kind of how the breakdown is. What you'll notice in the second set, and I've kind of highlighted or italicized the chapter 13 and chapter 19 where we spend the majority of time. You can see certainly that chapter 19 has a significant amount of the adds in there. It's a big chapter. It covers an awful lot of areas because it's injuries as it relates to anything, right? So, but there were a fair amount of musculoskeletal changes as well as the injury. Some things to note in chapter 13. So, some specifics, and you can see some of this in the changes in dialogue and links that I'll provide you. But like TMJ had a lot more specificity and laterality added to it to provide a lot more specific codes than just general codes. Another one that's heavily used by our certainly PT and OT space is cervical disc disorder. So they've expanded that significantly, and that now includes all the way down to the cervical joint level, right? So C1, C2, C3, that's been expanded, along with associated conditions of myelopathy, radiculopathy, disc displacement, disc degeneration. So a lot of specificity around. So those are areas I would kind of focus on with you get into musculoskeletal, and an awful lot. There's the non-traumatic fractures, some non-traumatic fractures. So when you think of fractures that may be caused by some disease process, such as osteoporosis or neoplasm, right, those fall on the musculoskeletal thing. So there's a lot more specificity around there with respect to those fractures. On the injury poisoning side, the biggest chunk and why we see so many is a lot of laterality added, so left, right, bilateral components added to a number of codes really drove that up. Also, a lot more specificity on types of injuries and fractures. So those things were in different body parts. The other big thing in injury, the injury chapter that I think we should focus on from a rehab perspective was a lot of laterality components were added specifically to dislocations and sprains. So you find that kind of in the SO3 and SO3.0 and SO3.4 areas of the of Chapter 19. So a lot of laterality added to those specific things. Really, and I would say the laterality makes up 70–80% of the code adds that you'll see in the diagnosis thing. So just be aware of it. It's not a ton of education when you're really, you zoom in on the specific areas of the high frequency patient populations that we see in our space. So good familiarity, get used to that, and start leveraging and using those more specific codes is going to be a very important thing to do. So just from a summary perspective, so the new 2017 code set, October 1 this year, right, consists of 71,486 codes now. Many guideline changes. So review the guidelines and determine how the changes will impact you. Again, you can focus on the changes to the guidelines, so the bold, the underline, the italicized, and focus on those areas in the guidelines that references the chapters we use a lot more of. And then obviously one of the big goals of this update was, and of ICD-10 was specifics, right? How do we get more specifics so we can have better data from a patient population perspective? So more laterality, more joint specificity as well. The thing to really keep in mind as you prepare for this is what sort of, we call the ICD-10, the CM flexibilities. So there's a fair amount of flexibility around, the do no harm last year when this went into play was, your codes didn't have to be perfect, right? So you could use a lot of non-specific codes. A lot of those flexibilities, both from a Medicare perspective and from your other payers, are going to go away. So you've got to be, you want to be very careful, not just in the codes that you're using a very specific code, the most specific code possible, and sequencing of codes. So a lot of the things you'll see in the guidelines is when should a sprain versus a comorbidity, and depending on how they're related, be the first code or the second code. Those are things that are important not only in capturing just having the right codes, but the sequence of the codes can be an important thing. You want to do some, I may do a little bit of a follow-up specifically on some of that as we move forward. We're adding a lot of training and education stuff for our clients on the community with respect to this. But I just want to make you aware of those flexibilities going away and preparing for those. So that's where you need to do your research kind of now with respect to what have you been doing and what can you do to help mitigate and make sure this is pretty seamless and it doesn't impact you. So from a coding tips, I had some of these I think I may have shared with you before. So, be looking at and analyzing some of your current data and practices by your facilities, by your front office staff, if they're assigning codes to patients, and obviously your clinicians who are responsible for the correctness of the codes from a clinical perspective. So, what are the average number of codes is everybody throwing way too many codes, or are they appropriate? Maybe they're undercoding. Maybe they're not adding comorbidity codes when they should be, right? That's a good thing to look at. Look at particularly the overuse of the not elsewhere classified or, the unspecific or unspecified codes. Because just using a 10 is great, but if there's a more specific code, then again, this may result in claim issues. Denials or rejections or follow-up, right? And you don't want to create any impacts from a financial perspective. When the practice is, you want to be able to use the most specific code. And it's not just about not getting paid, but as we're trying to do better data, the data is being used. I hate to say it this way, but I'm going to because I think we all feel this, sometimes against us. the more accurate the data is on what we do, how we do it, and the clinical relevance and efficacy of the care we provide, it's very important that we have coding right, particularly from a diagnosis and patient population groups, et cetera. And you do want to monitor denial rates. Are you seeing any changes by payer with respect to, once the new codes go into effect in October and you start billing, soon in October or the end of October, are you seeing denial rates go up for any reason by any payer? Are those tied to diagnosis codes? You can jump on that proactively very quickly and have a plan in place. Don't wait for it to occur. Have a plan to be monitoring that in advance. If you're not already looking at it, you definitely want to start looking at it now and then monitor that. And then track some of the changes, LCD changes that may occur with respect to some of the new codes. That's just more and more. ICD10 report utilization analysis and training. And so we've created some things on our community just for our clients. So where we've got some quick reference guides, how to be able to go in and pull data out of the system to look at diagnosis code utilization and do some analysis on that, so you can drill in on some of those top items like what codes are we using, et cetera, or what kind of non-specified codes or unspecified codes we're finding people using. And we're going to continue to add to that. We'll also do some sort of brief recorded webinars, things we used to call, and then we'll probably do some follow-up in 5s, just helping our clients with respect to that. The other thing that we've already made all the changes for the new codes and are available in an upgrade. And so if you haven't gotten an upgrade recently, and you go ahead and contact. I think we had a reference on that Megan put out recently in the newsletter with respect to that. So you need to get in touch with us, make sure you've got an upgrade applied, and you've got so you'll have all the new 10s, and you'll have the 10s that will become deactivated will be deactivated appropriately. So let's switch topics to, and again, I'm not going to spend a lot of time both on macro MIPS or bundled payments because they're not impacting us as much urgently right now, but we just have to continually be aware of them. And I would be doing everybody a disservice if I didn't cover these as they progress and evolve. So from a bundled payment expansion, so CMS published a proposed rule in August, specifically on some of the bundled payment expansions. So we know they have the CJR model off and running, and it's being used at, I think, over 700 hospitals that are testing and using the CJR model. So, this is something it's coming. So they proposed 3 new episode payment models, or EPMs. The acronyms will not end. I guess I'm used to the healthcare ones, but now we just can continue to create more. But new episode payment models, right? So those are proposed. Again, it's to test bundled payments for acute, AMIs, obviously the cabbages and the surgical hip fracture, et cetera. And so all got their acronyms. Those are things that are proposed. And then the one that pay more attention to is the cardiac rehab incentive payment model, because that's basically the exact same. The testing bundled models above are more testing data specific for episodes. They generate and capture data. But the cardiac program, the incentive payment model specifically is like CJR. Okay, so like the total joint model, this is yet another incentive payment model, right? So there's a penalty or an incentive to do this, and this is going to be proposed to be rolling out. So the target dates for some of these to become effective. Obviously, the payment models need to be implemented through rulemaking, performance periods, and could target as early as July next year. But you need to be just paying attention to these as they continue to advance them. Obviously, it's all about higher quality care, better impact for the patient, and cost savings. So there are going to be some refinements to the CJR model as well that were proposed, and so keep a lookout for that final rule. The comment period, I think the comment period goes till October 3rd, so they're ongoing receiving comments on the proposed rule and stuff. So we'll see something between now and the end of the year on a final rule with some of this payment model expansion. So again, you just kind of need to keep track of that. surgical hip femur component is functionality. That's the add-on to the current CJR program. So they expect to apply this to all hospitals that are subject to the current CJR. So again, expanding, they're having some success with it. They think it's an easy thing to expand, so they're doing that. And for the cardiac portion of the proposal, they're planning 98 metropolitan areas, which almost every hospital will be required to participate. So, that's that next sort of incentive model that's coming. Just be, and look for the comments, and you'll see a resolution after the comments. But if you're participating in this, if you're tied to a hospital that is, and I'll be updating results when after the final comment period as well. So spent too much time on that, but I know you just got to be heads up and be aware of it. So the 2017 Medicare proposed physician fee schedule came, and I'm not going to try to cover everything with respect to the proposed rule. And there's the CMS reference to 1654P. So, but I'm going to cover the payment rate update, the new CPT codes, eval and re-eval codes, Missvalued codes. I want to spend some time on that because I think we need to understand that, and then telehealth services a little bit. So we'll get into that. So just on the fee schedule payment rate, so the conversion, if you just drop to the bottom, the conversion factor for next year is going to be 37, 0.7751. So it's net down slightly from 37.8043, so it's just incrementally down. Why is it down, or how is it down? Because as we know, we got rid of the SGR, and so the actual update to the conversion factor was 0.5%. But also as part of some of the other legislation, there's the budget neutrality adjustment, which is -51. So it automatically washes away the update. And then there's an imaging MPPR adjustment of 0.07%. So negligible, so the conversion factor is going to be very close to or just slightly under what it was last year. So from a budgeting perspective. So, and these types of things, you're going to see the same, in and around the same rate changes probably for next year as well from a conversion factor. So let's talk about the change that potentially impacts us. And I did want to mention on the fee schedule, so the new fee schedule was published in July 7th. The comment period ended back in September 6th, and you may have seen APTA's summary of the comments they put in, as well as some others, and I've got references to those as well. Some things they liked and didn't like, and but the final rule will be published in November. But like anything, you can't wait to November to decide to prepare or respond to what's in the proposed rule, and so you have to kind of use the comment periods and feedback to get a sense of what is going to be what in the proposed will be in the final, and get some sense of that. So that ties perfectly into the eval codes. So when they came out in the proposed rule, you may have noticed or remembered that instead of being 97161, 162, 163, it was 97X61, 97X62, 97X63, and the same thing on the OT side and the re-eval side. Well, since they proposed the rule, AMA has published final codes along with some more detailed descriptions and some other detail. So I was on a call with a number of clients maybe 2 or 3 weeks ago and asking them, well, what did they think of the proposed rule, what things that concerns them, what about the new eval codes? And the feedback was kind of across the board, well, we're not sure they're going to be in the final rule. We think this may get pushed, just like ICD10 got pushed, and so we're not really doing a whole lot with it. Well, they're coming, right? So, Megan alluded to, so I was, kind of straight from Capitol Hill, right? So I spent all day yesterday in APTA with the APTA leadership team as part of a business leaders meeting with them, talking about a number of different things, including a lot of legislative and regulatory changes. And so these codes are coming. They will become effective Jan 1. And the previous codes, 9701, 02, 03, will no longer be valid. And so you need to prepare for these, okay? So these are the codes. AMA's published them. They're part of the code books. If you go buy them from AMA, they're available now. Stuff. There's no X's. So here are the kind of buckets, and we've created. I'll show you a link in a second. We've created a quick reference guide and sort of a cheat sheet to help you with education of this, and we'll make that available to you guys as well. It really helps kind of break some of this down. So low complexity, moderate, high, right? The plan was for these codes and all the stuff put forward by the association and the PT population in general was that these codes would have different values and different payment rates. Well, that's not in the proposed rule. They left the RVU at the same level as the current eval rate, which is 1.2. And so that kind of very frustrated, and a lot of the comments from APTA and others, a lot of frustration. What's the point, right? So no matter what I pick, I'm going to get paid the same. Yes, but they're using it for data collection, and we need to be careful about that. I'll talk a little bit more about that in a second. So some of the other vagueness is, okay, I get low, moderate, high, but personal factors and comorbidities. What do you mean by that, right? What's a personal factor? Comorbidities, I understand, and they have some language in there, and you notice the asterisks. So it's not just does somebody have a comorbidity, but is that comorbidity impacting the plan of care? Will it play a role in that person's ability to gain function for what you're seeing them for? That comes into play, right? You can't, just because they have 3 comorbidities, it may have nothing to do, or it may be hard to justify that that's impacting the plan of care. Body functions, body parts and functions, again, some, I think we know what you mean by that, but define that a little bit more. Stability, clinical decision-making, I think that's easy enough. And then the time component was probably another frustrating thing. So approximate face-to-face time. So the questions are, do I have to record time? The answer is no, right? You don't. It's sort of, this is what they estimate. But obviously, it always makes me nervous, as it probably does you, when they put a time component on something that's technically a non-timed code. How can that be, will that be used against us in some way? Do I need to make sure my documentation supports that untimed time code time that, that correlates to the complexity? So lots of questions with respect to this, but you're going to see an awful lot of vignettes and case studies that are being prepared both by CMS, AMA is doing some, but APTA is actively involved in doing that as well. So I think that's really going to be important to understand how and when you apply these components. So the AMA, when they just literally within the last couple of weeks assigned the final codes, numeric codes to the new eval codes, they also provided some more detailed definitions with respect to some of these areas. So body regions, an example would be head, neck, back, upper, lower extremities, and trunk. When they talk about body systems, they're talking about musculoskeletal, neuromuscular, cardiovascular, pulmonary, and integumentary. When they talk about body structures, they mean the anatomical parts such as organs, limbs, and other components, right? Personal factors, this was nice to get, so we don't assume anything. So when you talk about personal factors, is it, male, female, age of the patient, coping style, social background, education, profession, past and current experience, overall behavior patterns, so it's a pretty broad thing, but all of those things, how will they influence the disability and the experience to the individual? So how are personal factors related to, again, the plan of care? I'm going to try to open this up, but this is something we started. It's not done yet, but I wanted to. Oh, I don't think it's going to work, Megan. Oh, I went the wrong way. Well, anyway, we created a little reference guide that it's very nice one sheet, similar to some of the cheat sheets we created for the ICD10 crosswalking, which I think is going to help you, particularly with the eval codes, both the OT and PT eval codes, and categorizing them and understanding and how it plays as you go through vignettes and stuff. So I'll make sure that we get that out and make sure it's available to everybody. So On the OT side, same thing. So the codes have been updated. So no longer do you have the X where the 1 is. Little different categories. So yes, low, moderate, high complexity, but they have a notion of performance deficits. Then you have clinical decision making, which is the same, comorbidities, which is the same, but they talk about the comorbidities not just impacting the plan of care, but the occupational performance, right? And so again, lots of subject to interpretation, and then modification or assistance to complete the evaluation. So how involved, what kind of assistance or modifications do you need to make, none, minimal to moderate, significant. And then the time components, and the time components are a little different, right? So it's not the exact same time components for the low complexity OT to PT, and measuring that. So I didn't include the reevals on here, but we have those available, and they'll also be in our cheat sheets. I focus more on the eval code specifically. So again, the same thing here, the RVU's 1.2, so it doesn't matter. And the RVU for the reeval code, both OT and PT, is 0.6, which is what it is today. So a little bit more of the definitions. Again, these kind of came from AMA when they published the finalization of the codes themselves. So performance deficits, refer to the inability to complete activities due to lack of skills in one or more of the categories below. So then physical skills, cognitive, psychological skills. And they go into some more specifics as it pertains to impairments to body structures, balance, mobility, strength, endurance, et cetera, cognitive skills, problem solving, mental sequencing, those types of things. Which I think are good. We probably would assume that, but it's always good to have that. And I think these will evolve more in the vignettes and a lot of the stuff in education that's being planned with respect to, okay, great, you published this. But again, I would say, see this, I'll reference this, start, now these codes are finalized by AMA. They will become active Jan 1. Don't wait till the final rule. I'll probably say that 4 or 5 more times before I'm done today. Don't wait till the final rule. These are going to go in place. You need to prepare for them and do a lot of education with your staff, your clinical staff, and your front office staff with respect to these eval codes, and maybe even on the billing side, your back office staff with respect to these codes as well. So that's all I was going to cover on the eval codes and the re-eval codes. Another big component of the fee schedule is the potentially misvalued codes, right? So CMS identified 10 PT codes. It wasn't just 10 misvalued codes overall, but 10 were PT codes. And so the big thing I'm going to draw your attention to is 97110, therapeutic exercise. And the reason I have it in a different color and an asterisk there is that particular code wasn't just one of the top 10 PT codes. That was the number 3 overall overutilized code or potentially misvalued code in the entire CPT code set. So let's just say there's a giant bullseye or target on that code. And if you wonder how that's going to impact us eminently, not eminently, but within the next year. So a perfect example is the new eval codes that are going into place January. Well, one of the misvalued codes previously was 97001. And because it was dubbed to be misvalued, new codes were created around that, and that's why we have new codes. More than likely, you're going to see some sort of adjustment. I don't think you'll see a new code, but we're probably going to see some RVU changes, particularly to Therax, and maybe even some of these other codes in the proposed rule next year. And so while the misvalue is supposed to be whether they adjusting RVU either up or down, I don't know how much up is going to go, but more than likely in some of these codes, particularly the Therax code, it could go down. The reason they're doing this is all because of ACA, right? The Affordable Care Act that came out, and then subsequent to that, the ABLE Act in 2014, which is achieving a better life experience, right? So they set to identify specific misvalued codes that they would address in the fee schedules in 2016, 17, and 18. So and they have some budget neutrality targets, and their overall goal is to address this based on percentages, right, and to have adjustments. So well, the good thing is the percentages are small, 1% or 0.5% adjustments overall based on misvalued codes, but that's overall their goal, right? So it doesn't mean that Therex, and not trying to put too much fear in you, it doesn't mean that Therex can only go up or down RVU-wise by 0.1% or 0.5%. It could go up or down more than that. Overall, their goal is to achieve a certain threshold with these misvalued codes. So it's an ongoing legislative thing that is being, talked through and walked through very specifically. And so I just want to make sure you're keeping in touch with that, you're monitoring those things. Again, and you'll see more stuff come out of this. The only other thing I want to talk about with respect to the eval codes is when I told you I talked to a number of clients over the last couple weeks and months, and what I'm seeing in a lot of our clients, our PTs, are denial that these eval codes are going to go into place, and I don't think that's a very good approach. Or they may, but I'm going to wait until November. You can't wait until November. You need to, there's enough training and education that's going to have to go on between now and November. The only thing that might change in the November rule, and this is more opinion than fact, is will the RVUs still stay at 1.2 no matter what the code is? Or will they incorporate some of the recommended RVU thresholds to it? So that might change in the proposed rule, but whether these go active Jan 1 or not, that has kind of already been decided before the final rule gets published based on AMA's actions. Hopefully that makes some sense. So let's talk about the telehealth services. I included this because this is really a big buzz, right? So pretty disappointing for us that the PT codes were not considered at this time, or they don't look as fair. They're trying to get their heads around physical therapy services provided from a telehealth perspective. But so unfortunately, good comments back from APTA with respect to that. Good feedback, and a number of things. So obviously the end-stage renal disease-related services, the advanced care planning services, and critical care, those are things that, are eligible new codes and services to be furnished via telehealth. The nice thing is, and I'll allude to this later, is there's ongoing legislation, sort of a telehealth bill, right, that's in the House and going through Congress to add PTs to telehealth and PT codes to telehealth services. So, it's not going to, I don't think magically the final rule is now going to include PT codes, but they're hearing from us loud and clear, because when you look at the proactiveness of wellness and the things we can do to drive and reduce overall costs of care with the services that can be provided by physical therapy and occupational therapy, and the cost efficiency, being able to leverage that through technology and telehealth services. Not only that, but also the ability to reach rural communities via telehealth with those key and core services, I think you're going to start to gain a lot more attention. So keep watching this. We're looking at it obviously in two ways. Technology, we're talking to telehealth vendors and partners to look at integration with our solutions and systems to be able to make that a real value add you guys can leverage. But obviously, if you can't get paid for it or it's not going to be recognized, that makes a challenge. I think that's just a barrier at this point, but it was somewhat disappointing that it was not included. So the evaluation, I added some evaluation coding tips kind of similar to the ICD10 tips as well. So again, don't wait, right? I mean, we talked about this with ICD10 transition, but it's a pretty big change with these eval codes. And so lots of education, get them familiar with the new complexity code matrix now, start to walk through that. As I said, you're going to see some vignettes and case studies put out. I'm going to tell you, I think I've got it on later, but the APTA has a webinar week today that is simply on the new payment model, and it's heavily going to be on some of the new VAL codes, et cetera, And I know because when I was up there yesterday talking with them, their webinars cap out at 1,000 attendees. Well, when we were there, they were about to go over 900 attendees. So if you're interested in attending that, I think it's really good too. You know, their content is really good and they're actively involved in this. I would really recommend, because it's going to be a lot much more specific, and you'll also get a lot more information on the things they're doing to create vignettes and case studies, et cetera. So I really recommend you attend that, and I've got it on sort of a next steps slide later on. Prepare some of your documentation support. So understand, you know, what do I need to document to support the complexity? So am I documenting things, you know, like personal factors, comorbidities, you know, not just through diagnosis codes, but, you know, am I making sure that I'm referencing those things appropriately so it makes sense? So when someone sees you picked high complexity as an eval, you know, is it clear why when they look at your documentation? Same thing on the low complexity and medium complexity. So, you know, again, do that and do it collaboratively. That's my thing. You know, practice and use clinical vignettes or case studies. You know, do it as a group. You know, do it as a lunch thing, you know, in the clinics or however your organization wants to do it. But this is one of these other things that I think would be good to have champions either at the clinic level or your organization level to really drive this and be a core link, you know, to the source of truth and what's going on with this and how it's going to be interpreted and how you can leverage things to do it. Just to make you aware, we've made changes in the software already so that these codes will be available and the descriptions for low, medium, and high complexity will be available to choose and you know, do some things through prompting we can do to try to facilitate you completing the metrics based on what you choose. And we'll evolve that as well. But this just still all comes down to clinical decision making and the clinician making good decisions and understanding to justify it. Don't be dissuaded by the fact that it doesn't matter what you pick. You're only going to get paid, you know, you're going to get paid the same, because the two things to avoid is, you know, just pick whatever. It doesn't make a difference because the payment's not going to be the same. Don't do that. Don't just say, well, I'm just going to pick medium complexity because it's the safest choice. Because just like functional limitations, just like PQRS, they're going to use the data, and they're going to use the data to decide and assign RVU. If we don't do this appropriately, it will be used to our detriment and financial impact to us, and not really drive the efficacy of what we're doing and the care we're delivering. So really, you know, if we do this right, I think it's going to be well. So just really drive no shortcuts, right? Don't just pick the middle one because it's the easiest or safest, and don't arbitrarily just pick one, you know, the same one every time because that's just easier to do. So continue to emphasize awareness and training now, and don't wait, said it again, until the final rule is published, because these things are, you know, we're really getting, this is all the preparation for complete shift in the fee-for-service payment model and getting used to it. So I think it's really, really important you spend time on it. Okay, enough about that, and that's a lot. And there's going to be some really good more webinars that I'll link you guys to, and I'm going to be pretty active at the end of this year on Twitter because there's so much stuff going on between now and the final rule and stuff. So I really recommend if you don't follow me, or if you use Twitter, you know, follow me, and I'll try to keep you guys informed and good links and access to resources, and as I stay engaged in what's going on both on the Hill and you know, with the practice. So macro and MIPS update, really, really brief. So there was a big, like, oh my gosh, you know, so the MIPS program is supposed to go live Jan 1 for physicians, and so there was a lot of angst in the physician world, like, we're still trying to figure this out. The education's insane. We don't understand, you know, what this is. So you got to delay it. You got to delay implementation. Well, very similar to what we just talked about with the VAL codes is, you know, so good old Andy Slavitt kind of, you know, they took the feedback from this and said, okay, look, we want this quality program to go live for the physicians. So they've created this sort of payment program, pick your pace. So they've created options. So they have 4 options for the physicians and how they participate next year. So one is just testing the program, the other is participating part of the calendar year, the other is participating for the full calendar year, and the other is participating in one of the advanced alternative payment models. So then they've got definitions around those types of things. But again, they're dying to get the data, right, to continue to evolve the program in the MIPS program. So not having the data or it not going live is kind of not an option. So if you were to ask me, is MIPS going to be a go, no-go? It's going to be a go, but it's going to be a go with guidance and ease of utilization and ease of implementation with a lot of education that's being planned. So we need to keep a watchful eye out to this as we potentially become candidates for this in 2019, which I know seems a long way away, but this type of thing will impact us, before we know it. So again, I don't have a ton of content or slides on that. There's a link to this, describes what's going on, and I'll keep you guys updated as we see things. It'll be very interesting to monitor this next year because obviously PQRS goes away. This is the last year, and so they're moving to these more other quality initiatives and standards and data collection, which is something it's going to, will fall on us. So I want to talk a little bit about some upcoming regulatory updates or some ongoing regulatory and legislative things. Obviously, you can't be in Washington without kind of getting a sense of what's going on. And we tried to do this without talking about the election itself, but it's hard not to. So Congress is actually just back in session. They're back in session for a little while. Then they take a break, and then they come back for what obviously post-election, which is called the lame duck session. And so the lame duck session could be very interesting depending on what happens in the election. But it's the session between the election and then the inauguration. So, but anyway, there is some active legislation that is, that Congress, that is in Congress. So I wanted to reference some of these so you're aware of them and kind of give you a status update. Obviously, being an election year, it's kind of interesting. And obviously, these aren't the only things Congress is considering during this session and then on the lame duck session. So the Medicare Access to Rehabilitation Services, which is HR 775, which is the House bill, and then the Senate bill 539, right? That is the repeal to the therapy cap on outpatient rehab. So still an active bill, got real close to potentially passing last time. It didn't, unfortunately, but it's still out there. But obviously the cap right now only, I think, goes to end of next year. So, or the cap exceptions process. So there's lots of, the take or guess right now is this probably isn't going to get done because anything that's sort of tied to a budgetary note or a budgetary impact probably is not a lot of legislation that's going to get passed between now and the end of the year. And this one is one of those, right? So it's got the CBO, sort of has a pretty big impact on this. So that's probably not, we're not going to probably see a lot of movement or action on it. But if you want to track any of these or have somebody track on those, I think I put some links in here how you can easily, I follow them on like Twitter and LinkedIn and stuff, so I can get, whenever there's changes to these bills, I get pinged, I get updates, if more people are joining or status or if it goes into, if it goes into committee, et cetera. And those are all the steps and process, obviously, this legislation moving along. Good thing to do from your leadership perspective. The next one is prevent interruptions in physical therapy. So you guys probably know this more is the locum tenens arrangement. Obviously, this is an active one. This maybe has a little bit more hope because it really talks about it's so patient-focused. Interruption of care, there's things like this in the physician world, et cetera. So with the patient in focus, and obviously it can drive increased costs if there's big gaps in interruptions in the care that's being provided. So this may has a little bit more likelihood than the repeal of CAP does. But just keep in touch with that one as well. And again, I'm going to be tracking all of these and keep you guys informed. The other one is I wasn't as familiar with, but the Physical Therapist Workforce and Patient Access Act. That's a real interesting. That's really trying to, basically it's, legislation would authorize, physical therapists to participate in the National Health Service Corps, in their loan repayment program. So it would allow PTs to get up to $50,000 of student loan funding by, working for a period of time in the Health Services Corps. So, working in areas or rural areas or other areas that are underprivileged and dramatic need, et cetera, if you do that for a certain period of time, then you could get some pretty significant student loan repayments. So really interesting. This one maybe even has a little bit more action or traction. But again, it's so hard to know with the election coming what's going to happen one way or the other. And, because all these things have to go through the House and Congress, or the Congress, the House and Senate, and there is some risk that the Senate may flip from one party to the other, and that always plays a factor into these things. Just so it's not completely bad news on the telehealth, so the Medicare Telehealth Parity Act of 2015, that's a new House bill. There isn't a Senate bill with it at this time. So, but, this is really, good. Authorizes basically PTs, occupational therapists, and speech language therapists to provide telehealth services is defined. And so this is there's an other bill out there that does a little bit of telehealth for PTs and OTs, but it's only tied to Medicare Advantage, which is really, really limiting. So it's not really a great one. We're hoping that doesn't gain a lot of traction, and that this particular House bill is the one that gets more traction. And, based on the comments and response from APTA and some of the other lobbying bodies on our behalf, I think, this is one that may get some traction in teeth. Again, I don't see this one passing or moving forward this year, but that is one that to keep an eye on, particularly as we go into next year, because I think telehealth is going to be huge, and being able to get PT services and OT services covered under that will be very, very helpful. The Sports Medicine Licensure Clarity Act, basically that's when PTs and OTs, for lack of a better, when they have to travel with a team, that if, as an example, if you use somebody like the Denver Broncos and the therapist at the Denver Broncos, and the Broncos are playing in Carolina, and the therapist treats in the state of North Carolina, and they want, how is he protected, under the Licensure Act, because he doesn't have a North Carolina license, but he's traveling with the team, et cetera. This one actually got traction this week, and this one doesn't have a budgetary note on it, so there may be a possibility that this one actually gets enough traction to maybe even get passed. So there's no real budgetary impact to it. Obviously, it's more of a protection against, the healthcare providers that travel with the team, particularly the PTs and OTs, so and giving them some protection. The last one I want to let you guys know of is not legislative at this point, but it's more at the state level. So it says PT Licensure Compact. So this is really, really interesting and really good. So basically, it's trying to facilitate the ability where if I'm a therapist and for some reason I need to practice in a neighboring state, that instead of I don't have to go through the process of getting completely relicensed in that state. The compact would allow sort of this reciprocity where I could go be part of the compact, get approval process, et cetera, but that I could practice in another state. This has huge benefits and impacts because obviously there's some standards that have to be established from the clinical education components, et cetera. There still would be a fee you'd have to pay, and you'd have to get clarity between the states. So they've gotten 4 states to sort of sign up and agree to this. They need 10. They're very, they feel that it's not going to be a problem getting an additional 6 states to sign up, but that probably won't be till next year. But this could be something that highly valuable, particularly for therapists who travel, contract therapists, or even it really impacts the PT, themselves, and maybe the entity they work for, because if the entity they work for is paying for their license fees, but having to maintain CEUs and license fees in multiple states just to be able to go because the states can't get their acts together, that's kind of what this is going to start to break down a barrier. And this is also occurring in some other disciplines as well, like nursing. So that's going to be really interesting to get some teeth to it. So just a little update on payment reform timeline. So obviously October, November, you're going to get the final rule physician's fee schedule. It's probably going to be late October, early November. I think sometime around the first week of November, you're going to see it. The biggest change you're going to see is probably the final values or RVUs for the new codes, right? You're not going to see new code, no new CPT codes, right? Those are already published and now finalized by AMA. And so, but whether the 1.2 and 0.6 RVUs for eval and re-eval stay or will they go to levels, that's going to be in there. So along with maybe some other changes, but that's going to be the biggest thing I think to be looking for. But again, don't wait. Prep for these codes are coming because the codes are coming. It's just a matter of what the RVU is going to be. And then obviously Jan 1, the implementation, right? So the new codes become active and current, and then the 9701, 02, 03, 04 will be deleted. And so, be following, watching this again, and start to track what payers are going to do, not just Medicare. So what payers are going to do with respect to these other things and in managing that. Some states, Louisiana used to do this. I think Texas used to do this. I don't know if Louisiana still does, but on work comp, they actually had, maybe it was California, they actually had different levels of eval and different time components, et cetera. So it's not new. And obviously, as you all know, the physician's E&M coding is completely based on levels of evaluation. So upcoming events I want to make you aware of that I think are important. So obviously next week, 1 to 2:30 Central, 2 to 3:30 Eastern, APTA's new payment system webinar. Again, I told you there's probably close to 900 attendees. They cap at 1,000. It will be recorded if you can't attend or if that blocks an hour, so the slides and the recording will be available. But I highly recommend you registering for that. I'm registered for it. I participate in these things to stay in the loop to find out, as changes become so frequent, just to make sure what is the latest news. Go to source of truth like these types of webinars, et cetera. Don't rely on what somebody across the street said or what you heard, because lots of interpretation. October 15th, PT Day of Service worldwide. That's coming up, obviously, PT month. And then the APTA Private Practice Conference, for those of you who may be attending that, that's in October. I believe that one's in Las Vegas this year. And we can't forget November 8th, Election Day. It's going to be interesting to see what happens there. On the 10th, right after the election, I'll be holding the fourth quarter regulatory webinar. I'm really hoping that the final rule is published. If the final rule is not published or about to be published, we might reschedule that, because I want that webinar to come immediately after the final rules published in case there's any catches or surprises as we head into next year. And then I also put out there that February 15th, I think, to the 18th next year is the APTA CSM conference. And I believe that one is in San Antonio. I really recommend that conference. It's a great conference for a lot of content, regulatory content, really well represented, as well as the chapters and sections as well. Resources, I'll update this before you get the slides, but I tried to link all the resources just so you know from ICD-10. So obviously the CDC, the release, the new guidelines from CMS, the GEMS and code sets, particularly CBM. I really like the ICD-10 Watch link. It's one of the links I pay attention to as well. How to use KPIs to really, assess ICD-10 impact. Oh, I'm getting tongue-tied. So, but those KPIs are really, really good. Are you managing those KPIs, across your business, but specifically for ICD-10, they're really good KPIs if you're not looking at them. It gives you some insight there. Link to the, obviously, the payment models on the CMS Innovation site. just from a bundled payment perspective, and then APTA's bundled payment models, they're due to have an update on that. There was also in PT Motion, they had some news about the new cardiac incentive program like CJR. And then the value-based payment monitor is something else I follow pretty actively. And there, because as we continue to move to value-based payments, they're actively watching all of the bundle payment stuff, and there's some links. Again, they're also sources for a lot of the content that I leverage and share with you guys. Proposed fee schedule, you can see the proposed fee schedule on that link. You can see the comments that APTA provided and sent back to them. Any updates, I'll be tweeting out about the proposed fee schedule that we hear, or any additional comments that may have been provided to the fee schedule from some other disciplines. I'll try to share those as well. And then obviously CMS updates on the fee schedule, regulation notices, et cetera. And that's the link to the entire fee schedule. You can read it in its entirety, which is that 1654P. On NACRA, put a couple of links that are good. HIMSS really is doing a really good job managing and monitoring a lot of the MIPS stuff and the NACRA initiatives. That's a great organization that I stay connected with. Again, the value-based payment monitor got some detail on this whole options or choices and menu options for physicians for MIPS next year. And then links to each of the bills we covered off. So if you want, I think those links give you the ability to do like an alert me email if there's changes to the bill. So you can just leverage your email or Twitter to be able to track and follow some of these bills that are specific to our industry and business to see how they're changing. Again, I don't expect a ton with this set of Congress, and then the lame duck, I don't anticipate a lot. The other thing is that Compact Legislator, there's a little research kit, nice little PDF research kit APTA has. That's a good thing to stay on top of, because that may be very impacting for you as PTs, but also for your practices with respect to how you manage your staff. If you have staff that goes across state lines, or if you have staff that has to be licensed in multiple states and struggles with the management of those licenses, the costs, the CEUs, et cetera, it's a good thing to stay on top of. And so that's it. I don't know, Megan, did you want to wrap us up, or I think I went a little over my time.
Yeah, just a few minutes over. We appreciate you guys hanging in here with us and giving us a few extra minutes. Of course, if you want to learn more, we invite you to visit our website to learn about the company at sourcemed.net. We also have a new blog. It's at sourcemedblog.net. You can also access it through the website. David will be posting a recap of today, and he'll also be posting some other great information. Of course, we'll follow up on a lot of the things that are still in progress, and you'll find some things there out on the blog. Of course, you can follow us on our social media accounts. We're on LinkedIn at SourceMed. You can find us on Twitter at SourceMedCorp. David is at _McMullen, McMullen with an A. And then it looks like cut off our Facebook account, but we're on Facebook under SourceMed Solutions. We will be sending out a link to the recording as well as a PDF version of the presentation, and that'll come out probably on Monday. And we'll also include some of those cheat sheets that David had mentioned earlier. Again, thank you so much for joining us. We hope to see you next time, and we hope that you have a wonderful day. Thank you.
Thanks, everyone.